Hello and welcome to Yodo. Today I'm reviewing a booklet that is from the Department of Veterans Affairs. This video is not sponsored by the VA or paid for by any entity. I refer to this booklet, Setting Healthcare Goals, a guide for people with health problems. I refer to this booklet at work often as it's a good starting place for patients that have little or no information or exposure about life-sustaining treatments that are available. I will include a link to this booklet in the description box below. Although this is put out by the National Center for Ethics in Healthcare at the Veterans Health Administration, it's applicable to anyone. It is written in a basic and direct format, and the information is accurate. It is broken up into 7 sections: goals of care, healthcare surrogates, feeding tubes, dialysis, mechanical ventilation, and CPR. The last page of the book is just a small paragraph about telling us what matters to you. The Goals of Care section includes only a few suggestions of what patients might be wanting for their health. There are situations when cure is not possible, and this is discussed throughout the book, and it lists in this section thoughts, concerns, and goals when that occurs. We do not all want the same things, and depending on the circumstances, our choices may change. This booklet introduces topics to a patient and their loved ones and makes suggestions about what they might talk about with their healthcare team. Having the complete picture of a health condition, prognosis, trajectory, and outcomes bears heavily on a person's decisions. For many people, there is a difference between being kept alive and living naturally. It is advised for patients to explore their beliefs, fears, and hopes regarding the reality of end of life with their healthcare surrogate, because we all will die at some point. This booklet is a good source to provide information about life-sustaining treatments. The information source is a good starting place for people to have a better understanding of these measures. Life-sustaining treatments, or LSTs, sustain life. In some cases, they may restore life. In other situations, they are needed on an ongoing and continual basis. The success of the treatment depends on the medical problems of the patient. Each situation is unique. The LSTs were intended to be used for a brief period of time to sustain a person until their body can resume normal function. However, there are many situations that can occur resulting in a patient becoming dependent indefinitely on a treatment. This book explains when a sudden crisis occurs, the LST can bridge that person back, possibly, to the kind of health condition that they were in prior to that acute crisis. The book also explores that if a chronic illness has reached a terminal state, when an LST bridges that person, it's going to be back to that same chronic disease. LSTs are not curative treatments for chronic progressive disease condition. The next section reviews who should be part of this discussion and why others need to be included to hear the facts about the patient's health and learn that patient's belief system. This can be anyone, but typically it's a family member or a trusted friend. The healthcare surrogate is an important part of this conversation, as the surrogate must hear and learn what the patient would want. The book addresses a bit of information directly to the healthcare surrogate. This is a great introduction to this duty for the patient and the healthcare surrogate. It's very important that the surrogate understands and accepts the responsibility that comes with this trusted position. The healthcare surrogate does not speak on behalf of the patient unless the patient has lost their medical decision-making capacity. The medical care team will inform the surrogate when that time comes. Until that time, the surrogate needs to stay informed of the patient's beliefs or changes in their belief system so that they can represent that patient's voice when the time comes. Becoming an official agent for someone when they can no longer understand and communicate their wishes is an honor. It means that the patient trusts you to speak up for them. The healthcare surrogate must be able to answer the questions about what the patient would want for care. The choices are to be from the patient's point of view, telling the healthcare personnel what the patient would want if they could understand, appreciate, reason, and communicate those choices. Typically, the question we ask the surrogate is, what would the patient say now if they could understand their health situation and the outcome? Decisions should be made on the patient's belief system and not out of fear. The information contained in this booklet addresses the stress that many can feel when they are the surrogate. It reminds the surrogate that the patient's advance directive and the information about the life-sustaining treatment choices that the patient has pre-planned are very important. This is a guide for the surrogate, how to respond to the question that the healthcare team is going to ask. It's a position of responsibility and honor to stand up for someone's rights when they can no longer protect what they want. This is what it means to be a surrogate. Next, the booklet reviews 4 of the LSTs. It covers feeding tubes, dialysis, mechanical ventilation, and CPR. For each of these, the authors discuss what it is, how it's done, when the intervention might be considered, risks and benefits, as well as a brief review of what to expect and how long it might last. In the last section of each of these, there's a bit of brief and honest information about long-term use and the implication on the patient's lifestyle and the most likely limitations with ongoing use of an LST. The first LST covered provides information about feeding tubes and details a couple of different scenarios when this might be used and how it's accomplished. Some health situations can occur when the patient can no longer consume enough nutrition to meet their daily needs. It might be a swallowing issue, and the healthcare team wants to bypass the mouth to allow the calories to be placed right into the stomach through a tube. There's information about what to be expecting when there's a feeding tube being placed. The booklet does provide some examples and even suggests a limited number of scenarios when the feeding tube is more appropriate and a few examples of when feeding tubes are less appropriate. They provide information about possible risks and suffering that the patient might have when an end result could possibly be worse than a natural death from the placement of a feeding tube. The booklet discusses that when a disease process has reached end stage, some organs no longer process the provided nutrients, and the patient might not even be able to manage their water normally, regardless of how those nutrients and fluids are provided. That in those situations, feeding tubes may not provide any benefit and could put the person at increased risk for harm, pain, or possibly suffering. The booklet points out that sometimes patients are unable to understand that the tube is there to help them, and when they don't understand that, they might try to pull it out. So restraints, physical and chemical, may be needed for the patient to keep their hands away from the tube and allow that tube to remain in place. The booklet points out that not eating is a normal and non-painful part of the dying process. The next section is information about dialysis. There's a very brief review of 2 types of dialysis, peritoneal and hemodialysis. There's a description of the method of how each of these is accomplished. For hemodialysis, the brief paragraph reviews the circumstances when a patient has their blood cleaned through a machine. As this is a slow process of exchange between the patient and a machine, it typically takes 3 to 4 hours with constant monitoring. Right now, at this point in 2025, a trained human professional is still required to be present. For peritoneal dialysis, the blood is cleaned overnight while the person sleeps. Clean fluid from a bag is placed through the belly through a port, a tube from the outside of the abdomen into the patient's peritoneal cavity. The person's intestines float in this fluid for several hours overnight, and then the fluid, now containing those waste products, is drained back out through that tube several hours later. The review of what to expect with dialysis, possible benefits, and risks section touches on several real facts about dialysis. The authors address what happens when renal function is declining to the point that kidney failure is occurring. When there's a short review of some symptoms, it's encouraged for the patient to talk with their healthcare team and get detailed information about their symptoms: fatigue, weakness, nausea, issues with edema. The booklet does cover and address that there are measures available if a person prefers comfort-focused care to manage their symptoms without starting dialysis. They address that with and without dialysis, the food that a person eats, the amount of salt in their diet, and the volume of fluids that they drink does have to be monitored closely, as well as have an ongoing need for many medications: blood pressure control, edema management, prevention of bone loss, and to mitigate heart risks as much as possible. The book touches on lifespan with and without dialysis, stating that as it is so unique to each person, this should be addressed by the healthcare team to obtain the most accurate picture of their specific situation. The next section in the booklet is information for patients and families about mechanical ventilation. There is an accurate description of the overall process of both non-invasive mechanical ventilation and invasive mechanical ventilation. Non-invasive ventilation, or bi-level positive airway pressure, which is often called BiPAP, it's delivered by a mask that's placed over the nose and mouth with straps to secure it tightly in place. A machine is attached to the other end of the tube that goes to the mask, and that's what pushes air into the lungs. Invasive mechanical ventilation is when the machine pushes oxygen into the lungs through a tube that's placed directly into the windpipe. The tube may go directly through the neck into the windpipe, or it might go through the nose or through the mouth to get into the windpipe. Invasive ventilation is typically no longer than 14 to 15 days through the tube in the mouth or the nose until it's placed directly through a tube in the neck. There's a really brief review of a few lung conditions that might result in the need for mechanical ventilation to be provided, and that the breathing machine might be needed for the rest of a person's life. There's a general discussion of what to expect with BiPAP and invasive mechanical ventilation support, with that tube being used instead of the mask. Both are artificial methods of breathing, and sometimes patients are forever dependent upon this. The last section of the booklet covers CPR, cardiopulmonary resuscitation. There's an overall very basic description of the process of chest compressions and how this coordination with artificial breathing and medications are administered with intermittent delivery of electrical shocks into the chest, and that's in an effort to electrically recalibrate and restart the heart. The authors point out that intubation is performed during the process of CPR. There are a few words on when CPR is used, and that sometimes patients elect to not have CPR, ever. And this is called do not resuscitate, or in some areas of the United States, it's referred to as a do not attempt resuscitation. DNR or DNAR are the orders placed in a patient's chart in a hospital setting. The section of benefits and risks for CPR points out that for young and relatively healthy persons, they have a higher likelihood of being able to return to the same health status that they had before the heart stopped. Some of the scary but honest information and facts presented in the booklet include that only 1 in 6 people receiving CPR in a hospital will survive their hospital stay. The hard and frightening numbers are that 5 of 6 people receiving CPR will die in the hospital. For patients who do have a successful restart to the heart, there's likely going to be some chest soreness, possibly significant pain from the ribs being broken during chest compressions, along with possibly a collapsed lung or other internal injuries from receiving high-quality CPR. The booklet points out that surviving CPR events does not address the possible scenario of multiple problems that can occur with other vital organs that were maybe injured during the process of patients not receiving sufficient blood and oxygen supply while the patient was dead. The last section of the booklet proposes an assignment to the reader to take time to consider their priorities and what they value, to talk with the people that they trust and share their feelings. The patient and surrogate are to obtain truthful information from the healthcare team about their particular health situation and prognosis. The discussion needs to include likely outcomes of each of the various treatment options that are available to them. The review of the healthcare team needs to include the patient's priorities so that the patient can be given recommendations by their medical providers which medical services and treatments are most likely to help them achieve their goals. Now for a few critiques. In summary, I want to point out that the booklet does not review any information about blood or blood product or transfusion administration. I'm not certain why this information was left out. It must be intentional, and this truly is one of the 5 LST interventions. It was surprising to me the limited number of times that any of the D words were used. Death, dying, die, dead. The book really avoided this word. Certainly dwelling on that word is likely to influence the reader not to finish the book and to possibly feel hopeless, yet by avoiding the truth and outcomes that are resulting in these LSTs kind of waters down the information. Doing these discussions often, I don't disregard that word, and I use the death word or die word periodically, and sometimes patients will point out in their healthcare journey and the discussions with me that they don't think it should be avoided. Nearly every patient will tell me at some point in our discussion that they believe it's the responsibility of us, of the healthcare team, to bring up these difficult decisions and difficult topics, and that it squarely rests on our shoulders to offer to have these discussions. Many patients will ask me how much time that they think they've got before they die, what the process of dying will look like for them, and how they're going to know when death is close. The booklet completely avoids the hardest discussion, and that's when exploring the patient's value system. Patients need to consider if becoming dependent upon one or multiple LSTs, how would they answer the question, Are these treatments promoting life or prolonging death? This is why patients have to have thought through their value system and must communicate that with their surrogate. When these life-sustaining treatments are in place, many times patients are no longer able to have capacity. I truly appreciate the authors of the booklet encouraging patients to discuss these LSTs with their surrogate and to consider their goals and values. I was very glad for the material to address the surrogate in particular. Communicating the viewpoint of their responsibilities as well as the stressors that they feel is crucial. Too many times patients have not informed their surrogate about their health nor their belief systems, leaving the surrogate questioning themselves and hesitant to communicate decisions. The section on feeding tubes did not use the term artificial nutrition. Many patients I communicate with appreciate knowing that feeding tubes and placement of formula into the stomach is not a natural way to receive calories and nutrients. I have had patients and loved ones ask things about the contents of these feeding formulas, everything from nutrients and vitamins and minerals to preservatives that might be contained within them. Some are concerned that if this is started, the patient won't be able to eat at all. Patients are actually concerned about the loss of the joy that they receive from eating and the impaired socialization of those tube feeds. The booklet does not address the venous feeding topic. Some patients feel that this could be a long-term option for nutrition, and many are surprised to learn that even in the year 2025, we have to rely on the gut for obtaining and processing of our food. We just don't have all the means necessary to provide nutrients, calories, minerals, vitamins that are needed into a patient's bloodstream. IV nutrition is not a long-haul remedy. I was really pleased to see that the booklet specifically points out that not eating is a natural part of the dying process. Everyone realizes that death is near when a person does not eat, and the booklet actually contains the crucial comment commonly given to the surrogate and concerned loved ones when eating stops. The comment from loved ones regarding the concern that the patient will starve to death as they are no longer able or willing to accept nutrition or even water sometimes. Healthcare providers know that this is a natural part of the dying process and is not painful. The booklet provides the statement, "The person is not dying because they've stopped eating. Rather, they have stopped eating because they are in the dying process." In the section on dialysis, the booklet gives brief information on both peritoneal and hemodialysis. For hemodialysis, it mentions that this might be done at home. There is no data or statistics given, and this can be a bit misleading. In the year 2020, just over 10% of the U.S. population was utilizing home blood exchange dialysis. Patients, the government, insurance companies, and Medicare would like to see that percent of in-home dialysis patients climb to over 80%. A major issue to this is being done at home is the cost of the monitoring, as many patients do not have the expertise or want to accept the responsibility. Insurance companies don't want the expense of sending a trained professional to a private home 3 times a week for 3 to 5 hours. Currently, we're sort of stuck. There are significant criteria to peritoneal dialysis, and the booklet hardly touches on these specifics. Both hemodialysis and peritoneal dialysis have significant advantages and disadvantages, and these are not thoroughly detailed. I was a bit disappointed in the section on mechanical ventilation. This downplays the seriousness of any illness that results in a person being unable to breathe. This part of the booklet does not address that some patients might need support for a brief period of time and not require additional oxygen. They can get enough out of the room air. But that for most patients, room air is not only insufficient, but the patient may have difficulty initiating or completing a breathing process. The booklet does not remind the reader that the use of supplemental oxygen can be provided by nasal cannula, and for many patients, this might be sufficient. Additionally, the section on CPR is general and does not give an accurate description of the process, speed, or multiple people needed to provide for the patient's needs in this acute crisis. This section does not describe the process of a code blue or even use the phrase. The process begins immediately when someone's heart stops and the support personnel will leap into action. There's a significant difference between response to a code in a hospital setting compared to that response in a community setting, and the booklet doesn't describe that. It does not address the survival rates and outcomes for patients very well. They don't provide information on the rate and depth of chest compressions that's absolutely required for high-quality CPR. The booklet does not point out that a person has to be dead to receive CPR. It does allude to that when someone's heart has stopped beating adequately, and sometimes there are situations when a patient does require a shock to their heart because it's beating so fast that it's inefficient, but it doesn't describe that very well. The book phrases it something similar to cardiac arrest is another term for when the heart stops beating. This is a way to skirt around using the word dead. It's important to say what we mean and avoid euphemisms when we're discussing such important topics. I recently had a consult placed to reveal goals of care with a person just prior to their discharge home. It was about an hour before the patient was going to go home after a prolonged hospital stay. The nurse practitioner with me and I were puzzled why the consult was placed on that date of discharge, but we proceeded to meet with the patient. We were met by a very kind and quite elderly and very sick person that was open to us meeting them. We established who we were, that we were a part of the palliative hospice team, and that we were just going to review their choices and what was recorded in the medical record to ensure accuracy. We then confirmed full code and stated the chart indicates that you want CPR and you have chosen to remain a full code. The patient replied, "Everyone keeps asking about that, and if you think that's a procedure that will help me, could they do that today before I go home? I really don't ever want to come back to the hospital. I think I'm old and I think my time is short." The conversation from that point on took on a much different direction, and the patient established that they wanted the chart to reflect their choice of a do not resuscitate, and they signed the yellow community do not resuscitate form in our presence to take home with them that day. They assured us that no one had really gone into detail about the difference between a full code and a do not resuscitate code, and they had always wanted to be allowed to have a natural death. The last section of the booklet is only a brief paragraph to have the reader tell their healthcare team what matters to them. This does not address the harsh truth that some conditions are terminal, nor the unpleasant concept of mortality. Some of the booklet language is vague, and I suppose that that's intended not to offend the reader. Talking about LSTs implies death, and this is such a sensitive topic, and it can be easy to provoke complete shutdown of a person. End of life is a really tender subject. The numerous considerations, cultural, religious, educational biases, that's just to name a few of things that can interfere with a person accepting information. The authors of the booklet no doubt considered this when they put the information together. They may have kept writing brief and general so that the booklet will be short and not given much elaboration or discussion. There may not be many examples given in each one of these sections because of that, and if they would have, it would have made the booklet a lot longer. Providing offerings for further resources and where the patient or their loved one might gather more information if data could have been provided. They could put QR codes in the booklet or the online version that's there. They could link additional resources. I would suggest that there be a list of questions for the reader that they could print off and consider or ponder. The booklet could provide more detail of what it looks like when these life-sustaining treatments become permanent. Give the information of what it's like to the people so that they can understand what it would be like to fully be dependent upon these for the long term. Patients may not realize the impact and understand the changes in their daily life to forever need a machine running beside them just to sustain them. The booklet does not pose the question to the reader to concern where is the line to be crossed if there's a difference between actively living or being kept alive. I have reviewed on the channel another exercise for patients and their loved ones to go through, and that's the 5 Wishes booklet. This covers different material and in a separate booklet that also we provide to patients that have serious illness. If you have suggestions for other listeners or a specific question, please place those in a comment below. I want to support patients and families as they face situations that can occur when time becomes short. We all must be mindful of the importance of being kind to one another and enjoying the time that we're given. Bye now.